Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm here with Ellie Abel, who is a fourth-year medical student at Albany Medical College, and we will be interviewing today Dr. Erica Bliss, a family physician in Seattle, and she will be sharing with us a story about a major innovation which really showcased the power of family medicine. Dr. Bliss, thank you for joining with us.
Happy to be here.
For the listener, you're Dr. Bliss, an innovator who creates opportunities and then builds to take care of people in the way you just described. Can you give us an update on what you're doing now?
Sure. So Key Lions closed its doors in spring of 2017. And I, by necessity and also because I wanted to, struck out on my own as a solo practitioner. I couldn't imagine going back to fee-for-service medicine. I hadn't done it for 10 years at that point. And it was like direct primary care or die at that point for me. I just couldn't imagine going back to a system that would not allow me to take the kind of care of my patients that I had learned how to do. It had just been, it was too far past that point. So, and also I had a lot of patients who had entrusted me with their care for a long time, and I needed to be able to continue to take care of them. So I opened a solo practice called Equinox Primary Care, and a number of my patients, pretty much all of my patients, came over with me at that point. And, you know, as Q Lions dismantled and people went their separate ways, my patients and some other patients came with me. I continued the direct primary care model, so just very simple monthly fee. I don't take insurance, just like we didn't with Q Lions, so I don't bill anything fee for service. Extremely simple. I have one medical assistant who works with me about 80% time. I literally stood it all up in no time at all. I have, my practice is probably about 2/3 full now. And again, it's a wide variety of people from all walks of life, all ages, babies to people who are at the end of their lives. And I do comprehensive outpatient primary care. I have a little office in downtown Seattle, and I do, you know, some in-person care, a lot of telemedicine. It always has been that way, and what we learned at Q Lions has applied here too, which is that in general, once you get to know somebody, a lot of the care shifts to telemedicine. It used to be that a lot of it was by phone. What I found with the COVID crisis is that I'm using video a lot more because it's hard to, we all feel kind of out of touch. And so being able to see somebody's face, it has meant a lot more than it used to. So I've been finding myself rely on that a little bit more. But even prior to this, I think my schedule was easily 50% non-face-to-face visits or contacts, either phone or texting or patient portal messages or something like that. So that's been the case from the beginning. My patients have anything from very uncomplicated health and they just want to stay healthy and have someone that they can tap into when they have a question, to people who have extremely complicated health profiles and need lots and lots of management. So it's very interesting, never a dull moment, constantly learning. I absolutely love it, and have been really enjoying the shift from having grown to being the CEO of a fairly large company with a lot of stressors to being just running a solo practice and getting to focus in on the joys of direct patient care alone.
So what's happening with the COVID epidemic? How does that influence your development, your operations?
So unlike a lot of practices out there, or the majority of practices that have been struggling to switch over to telemedicine, it was literally overnight for me. already doing telemedicine as a big part of the practice and not having to worry about getting paid whether I was seeing people in the office or not. It was really it didn't require any thought whatsoever to just reschedule people and say, hey, let's not do anything in person until further notice. Unless absolutely necessary, I will call you, I will set you up for a video visit. And my assistant and I contacted everybody and just reshuffled the schedule overnight. What we've done is my patients are able to schedule themselves. And then if they need assistance, we can schedule them. So we just switched the online scheduler to only phone and video visits. And if they need an in-person visit, we screen them first before we decide whether we're going to bring them in. And then after about a week, I sent my assistant home and I went home, and we just have been working from home mostly. And I just go in to see people as needed. So it was literally like flipping a switch, made it so easy to flip over. And because I have a monthly membership practice, my revenue didn't take a hit, and I didn't have to worry about what I was going to do tomorrow or whether I was going to be able to keep her employed. And I was able to reassure her almost immediately, don't worry, you have a job. We're going to be okay. Even if a bunch of our patients lose their jobs, I'm just going to comp them their care. We won't worry about that. I figured it out. This is how much, I can afford to give away this much care before we have to worry. And even then, here's my plan B, and, talk to the landlord, et cetera, et cetera. So I was able to reassure her so she and her family didn't have to worry. I was able to make some plans. I was able to budget for what I could do in terms of patient care, so I could reassure my patients that they didn't have to worry. It was so nice to be able to immediately say, within 2 days, I had a whole plan, because I had control of my revenue and I had control of my delivery system, because it made sense in a situation like this. And I could just flip everything into disaster mode, basically. So that's what we did. And then I was able to immediately be there for my patients in a very efficient way that basically a bomb could have fallen on my clinic and blown it all up, and I would have still been completely fine. No problem. So, and I, by that time, had become so comfortable with telehealth that I didn't feel like I needed to develop a whole bunch of new skills. I already was very comfortable with assessing patients over the phone and by video, and having them pass me information back and forth by photos, by home blood pressure and other assessments, by monitoring things over the course of several days and feeding me information. I had gotten very comfortable with that and understood what you can watch, what you can't watch. When do I have to send them in to get labs? When do I need to do this? When do I need to do that? It's something that I've realized is a skill set that you grow over time, just like anything else. When you first do it, you feel a little bit nervous about it because you're so trained, you have to see the patient and lay eyes on them in person and put your hands on them. But you start to realize there's a lot you can do without actually having the patient in front of you, including things like I just did a video visit with a mom and her child yesterday. And I was trying to figure out what's going on, whether this is sinus or ears or reflux or something like that. And I realized I could have the mom tug on her ears for me. Is this an ear infection of the ear canal? If she tugs on her ears for me and the kid isn't feeling any pain, that tells me something. If she taps on her face over her sinuses and the kid isn't feeling any pain, that tells me something. If she presses on her belly for me and the kid doesn't flinch, that tells me something. So someone can actually help you even with physical exam findings and give you a good idea of how bad the person might be. Just looking at them on a video and watching them breathe. I've been doing that with a lot of patients. Watching them breathe in and out, you can tell a lot about how comfortable they are. You don't necessarily have to listen to their lungs. So that's the kind of thing that if you do this for a while, you get a lot more comfortable. And if you know those patients, you know how much you can rely on them to use good judgment about their own symptoms. And if you're not sure about them, you can just check in with them every day and make sure they're okay. Anyway, all of that together, I have found that it's been really easy to get patients reassured, healthy, safe, out of trouble, et cetera, et cetera. And throughout last month, I've only had 2 people have to go in for anything out of about 400 people. And those were for non-COVID related issues. They were for other things that really had to be addressed. Otherwise, we've been able to keep everybody at home, and I've been able to monitor everybody and all that kind of thing. I'll pause there for a second, then I can talk more about the telemedicine potential, but let me stop for a second and see if you had any questions about that.
Allie, any questions?
Not at the moment. No, I'm fascinated by what you're saying, Dr. Bliss.
So I'll talk a little bit then about the potential for telemedicine, because one of the things that I did, I was sitting around when this whole thing hit thinking, God, I wish I could do something. I'm really worried about my colleagues in the hospitals, but I'm not part of the hospital systems anymore. I'm an independent doc. I'm not credentialed at the hospitals. I don't serve in the hospitals. I'm really worried about what's going to happen if we get hit with a big onslaught of patients, and I want to be of service. So I signed up for the volunteer service corps and all that kind of thing. And, was sort of sitting, biting my nails, wondering what was going to happen. And then I thought, well, what can I do? What can I do? What can I do? And then I started hearing about all these patients who couldn't get in to see their doctors, or didn't want to go in because they were nervous about getting infected, or couldn't get a hold of their doctors, or didn't have a doctor. And it suddenly dawned on me, while there was all this discussion about telemedicine and getting paid for telemedicine and getting set up for telemedicine and on and on and on, I thought, well, I have some capacity in my practice. I'm not busy every second of the day. I could offer a telemedicine membership that, as they were relaxing the requirements cross state lines and all that kind of thing, I thought, well, I could just offer this to anybody. And so I decided to set up a telemedicine only membership for anybody who wanted it. For the duration, I decided to just make it available for 6 months and decide after that what I wanted to do with it. So I set up a telemedicine only membership. I decided to just set up a charge of $25 a month, which would sort of help defray my costs. But be low enough that hopefully it wouldn't be a barrier for people. And I, of course, would negotiate it with people if they couldn't afford that. I just, I was throwing a spitball against the wall. It wasn't intended to be something to make money off of. It's probably lower than my actual costs, but, I just didn't want it to be a huge barrier. And the idea would be that people could have unlimited access to me via phone, video, texting, etc. And I would be their primary care doc, or a supplemental primary care doc, for the duration of this crisis while people can't get good access to care. And it wouldn't be just for COVID-related stuff. It would be for any primary care issue. So that while the healthcare system is in chaos, they don't postpone or avoid getting care for things that are important. And the other thing that inspired this was that there were telemedicine options for things like, can I qualify to get a COVID test? And I had a patient call, because we didn't have a lot of testing available here. We still don't. And one of them, the family sat on the phone for 2.5 hours, finally got through, and they literally had less than 2 minutes on the phone with the doctor who screened them appropriately. And turned out he didn't qualify to get the test. And then that was it. There was no room or time for any other questions, because they had to get through all the other calls. And that kind of, for me, culminated the whole thing, where it was like, well, people have other questions. What about family members? What about this? What about that? People are just going to have a whole lot of health questions. Who are they going to call? There's nothing else available right now, and nobody has time. So that's when I started to remember, when we were running Q Lions, what we were starting to try to do when the company had to close down, which was, we had started to think about a clinic without walls and where the healthcare system really should go. And I thought, well, now is the time we really should sort of revisit this whole idea. So the idea with that was that there should no longer be this idea that all healthcare has to start with a one-on-one sit-down visit with a doctor. That you shouldn't have to establish a primary care relationship. Why do we have to have a face-to-face visit with a doctor or a nurse practitioner which is a very difficult to obtain, costly, time-consuming thing to, quote, establish care in order to get access to care. Why is that the gate you have to get through? Because what happens then is people avoid establishing care with somebody until they have a need, and then they have to wait, and then they have to go to an urgent care or an ER, have an encounter with somebody they don't know, it's in an expensive setting, they've put it off until the last possible minute, and that's the worst time to get a problem taken care of. So we said, why not have the channel set up beforehand in the lowest barrier possible way so that people feel that they have some sort of primary care relationship and it's there, so that when they have a need, they don't wait so long. They just tap into it and then they go from there. So what we started offering with Q-Liance in the last couple of years of its existence was a program we called Access to Active. And we got most of our employer customers flipped over to this program, where we said to them, just sign up all of your employees. Put them all in the access mode, which is essentially a telehealth option, where they all have access to us for telehealth. They don't have to switch their doctors. If they have somebody else they want to see, that's fine. But they also have us for telehealth. And what we will do is reach out to them and say, hey, we're here. If you want, fill out this health history questionnaire. We'll put it in our system. And then if you ever need us, you just contact us. We'll know a little bit about you, just very basic health history like allergies, medications, and what your health problems are. Nothing more than that, so it's not invasive. And that way, when you call us for a problem, we'll know who you are, we'll know a little bit about you, and it'll be really easy to get you taken care of. And we already had a 24/7 telehealth service set up, and we had 7 clinics and a whole bunch of providers available, so it was easy for us to handle that. And then people stayed as access members up to the point that they decided they wanted to make us their primary care provider. And then they would switch over to being a full primary care member, and that's when the fee would go up to the employer. And so the idea was that we would make it really, really easy for people to access primary care, but they didn't have to have a sit-down appointment with us in order to start that relationship. So using that idea, what I did with my telehealth model is I said, you can join as a telehealth member. It's a lower fee. I'll do an onboarding visit with you if you're willing to do that. And I just got on video with these folks. I had them fill out a health history form. I went through the whole history with them. And if they had a health question or problem or anything, we talked about that. And if they didn't, we just said, well, nice to meet you. If you have any questions or issues, I'm here. Here's how you contact me. We're good to go. And you can continue this membership as long as you want. I'm doing this for at least 6 months. If I am not going to continue the program at 6 months, I'll let you know. Otherwise, you're welcome to stay on as long as you want. And if you want to change and become a full member where you can come into the office, you're welcome to convert at any time. So I set that all up, and I sent an email out to all my patients, and I said, hey, try to help people who don't really have good access to a doctor right now. I'm setting up this membership. Feel free to send this out to anybody you know who might be able to make use of it. And immediately, a bunch of my patients said, hey, this is great. I'm going to sign up family members, friends, people I know, or I'm going to send it to them. And a lot of them actually sponsored friends and family who they were concerned about, who were either in isolated areas without good access, or who didn't have doctors, or who were parts of systems where they didn't think they had good access to their existing doctors, or whatever the case may be. And so I probably got about 20 telehealth patients signed up. And I'd say about half of those have actually contacted me or agreed to, we reached out to all of them, but about half of them have actually connected with me. And we've had a telehealth visit either just to onboard them or to deal with a specific problem. Some of them have been COVID related. Some of them have been completely unrelated. Some of them have wanted a second opinion on what their own doctors are telling them, which is kind of interesting. So it's been all over the board, and it's really made me stop and think about, we really need to do this. This could be a much more cost-effective, comprehensive way to get people good primary care in this country without having to build a whole bunch more clinics and worry about and much better utilize our existing primary care workforce while we work on building a bigger primary care workforce, to unclog our clinics and bring down the walls of the clinics, rather than everyone having to have this in-person, established care visit. We could have an established care visit with everybody via telehealth, get everyone up to speed, and then determine by meeting all these people virtually who actually needs to be getting into the clinics for care, prioritize those people, and then work our way through the population. So we could actually make the clinics into population health managers, sorting through people and prioritizing who needs to come in, kind of like they're doing right now with the COVID crisis, right? This is kind of what clinics are starting to do now. They're doing this by necessity. They're having to filter through people and say, you sound really sick, you need to come in, here's how we want you to come in, I want you to stop here and do this and do this and do this. You sound like you're fine, you stay home. We're going to call you tomorrow and check on you and make sure you're okay. For now, stay home and do this and this and this. You sound fine, but you're really worried. We know you're really worried. Okay, fine, you can come in, etc. So it's a much more orderly utilization of clinic resources and medical resources than we've ever seen. And it makes sense to do it that way. So we've been sort of forced into an orderly utilization of resources that we have refused to do until recently. All I'm saying is that the monthly fee model facilitates that. It's not magic. It's just a business model that has allowed a lot better organization, utilization of resources and care to do what we're now being forced to do as a society. And it creates, and the one other thing I'll say about this too is that we've had telehealth for a long time. The problem is that US telehealth services like Teladoc and American Well or whatever, I'm not picking on that, I'm just naming companies so people know what I'm talking about. Those services are not what I'm talking about, because when you call telehealth or any of those other programs, you get a random provider. You call up, you get connected with whoever's available, you tell them your problem, and they give you advice. You say goodbye, that's it. You're never going to connect with that same person again. There's no continuity health record. There's nothing that connects back to your overall health over time. There's nothing that connects you back necessarily to your primary health care provider. This model is primary care telehealth, where you are connecting with your primary care provider over time. And if you do this on a larger scale and it's one system, then even if you do connect with somebody else because your primary care provider is not available, that other person is connected with your primary care provider and is going to communicate back to them. Just like when you talk to your practice's doctor on call, who says, okay, I'm going to tell your doctor on Monday about this and we'll get back to you. So you feel like it's the same person or their colleagues taking care of you. You're not just talking to a whole bunch of random people and things are getting missed because it's all spread out across time and space. So this idea is you take telehealth and you bring it to the primary care level and it's managed at the primary care level so that people get true comprehensive health care.
So Dr. Bliss, I just want to say I think this is brilliant. We might rename it millennial care, because what you're describing is the kind of thing that I've heard many millennials say they don't want to engage in a deep relationship. They don't want to go in heavy, so to speak. They have a problem, they have an issue that they want to talk with somebody about. And I think if this allows them to build a long-term relationship with a primary care practitioner or a primary care practice, that trains them and guides them in the right direction. So if they do develop something more substantive, that they have a relationship and they're not just lost in the storm, so to speak. So I'm going to bring things to close because we are about to run out of recording time here with the platform that I'm using. And I will just ask if either you or Allie has any final comments.
I would just say that, as I think so many people are saying right now, if you look around the world at any great social change moments, any great any great systems that have been brought into being, any great social changes that are brought into being, they never happen just because people say, this is a great idea, we should do it. They only happen at times of great upheaval. Some things have to break in order for new things to come into being. So I think, you know, the history of the NHS is a great example of this. I think that that's potentially what we're looking at here. And while this is a terrible situation to experience, i.e. a global pandemic, it is throwing into very great clarity the shortcomings of the American healthcare system, right, and potentially giving us the opportunity we need to make some tremendous changes. So I really hope that the American public and political leadership will recognize this opportunity and really push for some fundamental changes that will make it better for everybody.
I'm with you. Allie?
I completely agree. And Erica, your outlook on medicine and the healthcare system that began as a medical student, I completely identify with. And I want to thank you for taking your career to show what's possible. So thank you.
Well, thank you. And I'm so glad you're joining the ranks.
Yeah, thanks.